warm welcome to those attending and also to our viewers watching live on the Council's YouTube channel, Hillingdon, London. This is a meeting of the External Services Select Committee, and my name is Councillor John Riley, and I am the chairman of this meeting. A key role of this committee is to monitor the performance of local public services within its remit and to hold in-depth reviews on topics of resident interest. We engage with a range of external witnesses in our activity, which can include community groups, residents, and subject matter experts. Where we identify areas for change or improvement, we make recommendations to the decision-making cabinet. Details of the business to be considered today are shown on the agenda, copies of which are available in the room and also accessible on YouTube underneath the broadcast. For those present in the room and intending to speak, please note that you will be filmed and any statements you make will be recorded and made public. For those in the public gallery, you will not be on the camera. A reminder to councillors, officers and those speaking today that you should turn the microphone button on when speaking, and this will ensure that you can be heard in the room and by those watching online. As we go through the meeting, people can introduce themselves as they speak. There's a lot of people around the table for us to introduce right at the start. So I'll ask, as each person speaks for the first time, perhaps they can say who they are and where they're from. Before we get started with the main agenda, some quick housekeeping. Fire alarms, we're not expecting a fire drill. So if the fire alarm goes off, please follow officers to the fire exits and out the building to the designated meeting point, which is in the Civic Centre forecourt. Mobile devices, for those in the room, please switch off any mobile devices before the meeting starts or put them on silent. Please note that some councillors may be using tablets or laptops to view the agenda. Resident feedback forms, you are welcome to give feedback about this meeting. Resident feedback forms are available in the room, and there's also a version online under the broadcast. All right, thank you. So we'll start with item 1, apologies for absence, and to report any presence of substitute members.
Chairman, we've had apologies from Councillor Lakmana, and Councillor Money is here as her substitute. Councillor Nicola Brightman is here as Councillor Arnold's substitute, and we've had apologies from Councillor Milani.
All right, thank you. Any other apologies or substitutes? Nope. All right, thank you. Item 2, declarations of interest in matters coming before the meeting. Anyone got anything? Nope. All right, thank you. And just to say that all items marked in Part 1 will be in public, and any items in Part 2 will be considered in private, but I don't think there are any Part 2 items. Item 4, minutes of the meeting of the 30th of April of this year, and you'll all have seen the minutes. I don't know if there are any specific matters that anybody wants to raise. There was a lot that we heard from CNWL as far as their report to us was concerned, which was all very, well, a great deal of it was very positive, and positive in terms of ongoing work that they're undertaking. And I think it was generally considered because it was so positive, it would be an idea for other trust partners who come to this committee to have a look and see what CNWL were doing, and to take some good practice from what they've been up to as well. Anybody else got anything on that? No? Are these agreed? Thank you. Minutes of the meeting of the 1st of May of this year. These start on page 9 at item 5. And again, discussion about various topics. Actually, just going back to the earlier minutes, you see that we've got 9 issues that we resolved to deal with, and very often what happens is that during the course of the presentations. Things come up. Members ask questions about things, and people who are doing the presentation will then say that they'll send additional information forward. And some of the 9 resolutions that we got around to have been dealt with. Others are in the process. And similarly with the resolutions that we have into the later minutes that we're dealing with. And item 5, some of those have been done and some are being dealt with. So anybody got any issues as far as the minutes at agenda item 5? No? Agreed? Thank you. And finally, the very brief minutes, which was the meeting of the council where this committee was put together. All right, thank you. So let's move on then to item 7, which is the update on the implementation of congenital heart disease standards. So where are we going? Who's starting on that?
And I'm Claire MacDonald, and I look after all the communications and engagement with patients and others on the programme of work. So thank you very much for inviting us here again this evening. It's been a pleasure to come back since I think we were last here in 2017. So this is a long programme of work, and it covers many, many years. Some people I know will be new to the subject, both of congenital heart disease, the standards and how they're delivered. So just a little bit of background so we're all on the same page. So congenital heart disease standards were consulted upon and developed by patients, clinicians, communities around that in 2015. The standards were developed so that they would ensure there was no variation around the country, that we had excellence of standards, and that those... Bisto. Thank you. There's a slide that I shall move us on. There we go. As I was saying, they were developed so that there wasn't the variation in standards around the country, that everybody with congenital heart disease could expect to get the same standard of care no matter where they were treated in the country. As I said, the standards were developed by all the clinicians, families, patients, and providers involved, and they run for over 200 standards for each level of care and also cover children's and adult services. Congenital heart disease is something that you are born with. It affects about 8 in every 1,000 births in the country, and it can have also a very wide variation of disease types. So it can be sometimes a more minor, something like a hole in the heart, which may not be very minor to you, but in terms of severity and treatment can be very different to some of the children with things like hypoplastic left heart syndrome, where they're going to need a lot of care and attention and often surgery very, very soon after birth. So it covers a wide area. There's a lot of intensive care and support required for these people. And the patients and families also require additional care, and the standards cover everything from where you are born, how you are treated, where families can stay, and the support that needed to be able to live lives nearer to home as well, right through to bereavement and care after that. We looked at all the hospitals and providers around the country, of which there are 10, and 3 of which we have in London. One of those, the Royal Brompton, and my colleagues here, couldn't meet one of the standards around paediatric co-location. So this means having all the care provided for children with congenital heart disease available on one site. The Royal Brompton proposed, in order to meet those standards, a partnership with their colleagues, the Guys and St Thomas' Trust and the King's Health Partners, so they could, in order to deliver the standards, they would form a partnership and do that together, because then they would be paediatrically co-located. That in the Evelina Children's Hospital you have all the services that children and families require. So if I flip on, for those of you who aren't aware, that's the Royal Brompton Hospital. Pictures. And just so you can see where we have that care provided for in London, so we have 3 centres of care. So the Royal Brompton of one is which, Then you have the Guy's and St Thomas's Trust providing both adult and children's care on the St Thomas's site opposite Westminster and the Evelina Children's Hospital. And then Great Ormond Street and Barts form a partnership and deliver the adult and paediatric care. So we have, of the 10 in England, we have 3 in London currently. I'll just use this, it'll be easier. Now, some of the services that are delivered there not only cover the congenital heart disease services, they cover other services, for respiratory in particular. So there is the children's heart surgery that I've talked about, and also intensive care that these children require. We've got respiratory services, so things like cystic fibrosis, primary ciliary dyskinesia, and then other very severe and specialist respiratory care. Then there is also adult heart surgery and the interventional cardiology that goes along that. That covers the congenital heart disease services, but other non-CHD structural heart care, and then also things like inherited heart conditions. There is the adult respiratory services, and again, that mirrors some of the paediatric services, but also has some things in additional, like interstitial lung disease and severe asthma there. Thoracic surgery, which is in main looking at lung cancer. And then those people who need long-term ventilation at home, and the hospital there support those in hospital and at home. And then finally, the adults who require the respiratory ECMO. Now, ECMO is, as you see there, extracorporeal membrane oxygenation, but it's a kind of I would always describe a form of life support in terms of that, for people who are very, very unwell. Now, Hazel is going to walk through a few of the proposals here.
All right, thank you. Perhaps it would be useful if we get some comments from Nick.
Thank you, Councillor. Nick Hunt, Director at Royal Brompton Harefield NHS Foundation Trust. I will immediately pass that particular ball to my colleague Piers McCleary.
Thank you, Mr. Chairman. I'm Piers McCleary, Director of Strategy at Royal Brompton Harefield. I've just got 2 points I would like to add to Hazel's presentation. Firstly, the proposal that we've come up with for our collaboration with King's Health Partners is not just to meet CHD standards. It's about meeting a much broad array of issues. So things like the space, the capacity, and the condition of the Royal Brompton estate, which has buildings opened in 1860 which are just not fit for purpose for arguably the leading respiratory hospital in Europe, if not the world. We have financial issues in terms of the scale of what we can do in terms of maintaining rotas in areas like radiology, lab medicine, and so forth. We have very much ambitions to fulfill a much greater level of academic potential, which this collaboration would give us, and it also gives us the ability to deliver better care at a more detailed or a lower subspecialty level. So this collaboration is very much a lot more than about meeting a set of standards. It enables us and our partners from Guy's and Thomas's and King's College Hospital to create something truly transformational across a multitude of services. So that's the first point I'd like to make. The second one is, because this is about the whole array of services, any third option that seeks to pick off a number or a group or a subgroup of services and deliver them elsewhere just doesn't work. There is a very well documented, we've been documenting it since the era of Safe and Sustainable in 2012, a domino effect that were you to remove pediatric cardiac surgery, you then weaken a whole number of other clinical services linked to it that extend all the way through all of the pediatric services and a good number, probably about half of our adult services. If you render, therefore, if you take away pediatric CHD, you render pretty much the majority of all the services at the Brompton unsustainable. The effect on that, obviously, is it destabilizes the entire trust, and most notably Harefield Hospital. So that is why our proposal, our collaboration with KHP is very much about all the services, and it is not just about pediatric CHD. I'm happy to answer any other questions you have, but those were just the 2 points I wanted to make. Thank you.
Nick, have you got anything to add?
I would make a point that I'm not accusing Hazel of this, but the idea that the proposal emanating from Imperial and Chelsea and Westminster is in any way a balanced alternative is not our point of view.
That's a good point.
All right. When this first came up, there were concerns about the knock-on effect, not just to a small number of services, but clearly to a very wide number of services and specialisations. And one of the issues that we discussed previously was the attraction and availability of experts, and the extent to which perhaps driven away is too great an expression, but certainly the complexity of keeping them, especially in relation to Harefield. And that's not just because it sits within our borough, but because it's a centre of excellence worldwide. And from what you've said in your report, essentially what there seems to be is that there are two blocks, as it were, Royal Brompton and King's, and then, as you say, Imperial and Chelsea and Westminster hospitals, and you've introduced a sort of third possibility and a scoping for others even. What certainly residents in this borough, and I suspect other areas, are going to want to be assured of is in terms of some sort of certainty and timeline as well. And in that sense, going for the best block that offers the best service across a range of complicated procedures and complicated services. In what sense? And I know it's a very complicated system and a very complicated way of looking at things. But in order to create centres of excellence, there's a bit of a theme going through everything that we're doing this evening. Are you looking at the broader aspects that Nick and Piers have alluded to? Because they're talking about something that's pretty apocalyptic as far as Royal Brompton and Harefield are concerned. That if you remove congenital heart disease and paediatrics, as we've discussed, that takes away the foundation of pretty much everything that they do. One of the things that is said in the report, of course, is that there will be no change to Harefield Hospital as a result of this proposal, which is also managed by Royal Brompton. But we're hearing from RBH that it certainly will, and that the knock-on effect could be very, very serious. So is that really being factored in a way that you're happy that wouldn't, I mean, taking the contrary view essentially, that wouldn't have such a dramatic effect? You talked about movement and travel of patients, and again that's something that comes up in other subjects that we're dealing with tonight generally, and I think you said there were 3 in terms of the centres of excellence. There's 5 in the country and there's 3 in London. Sorry?
10 in the country as a whole.
10
and
10 in the country,
London.
and we've got and there's 3 in London, and in a sense, given the geography of London and the southeast, it's always going to be something of a challenge for travel, and with the imperative in another sphere of it being public transport travel rather than personal vehicle travel. What sort of conversations are you having with TfL and the Mayor's Office in relation to different types of access, or perhaps even newer methods of access to either of these ideas? Dr. Hudge, if you may have a few comments on this.
Thank you, Chairman. Yes, just a reminder to members that I did formerly work in specialised commissioning, initially at London Specialised Commissioning Group, and then with NHS England once it was formed. And I was involved in the national standard setting bodies for paediatric cardiology and congenital cardiac surgery, although I wasn't in any way involved with safe and sustainable, I should add. And I think with that in mind, to see that we're potentially close to reasonable and consensus solutions, I think is extremely heartening, because not that long ago we were a very, very long way away from this. I suppose I have one question, one thing to tease out a bit more in my mind, and it relates obviously to Harefield Hospital, because that's perhaps more important as a local issue than some of the other issues. Do the experts feel that there is potentially a difference in the sustainability and security of services at Harefield Hospital between the two options, between the RBH King's College option and between the preferred option and between the Imperial Chell West preferred option?
Thank you. I'm happy to take that. We do have a definite preference, and that's to maintain our independence, to maintain our income and maintain our spread of patient services. The North West London proposal is not very well worked out, but very briefly it works on the basis of selling the Chelsea site and redistributing the services apart from paediatrics around to the benefit of Imperial and Chelsea and Westminster. So they would use the capital receipt to their benefit. We think that would not be to the benefit of the future of the services we currently provide.
Just stop. Well, I think residents might be worried about, and certainly users of Harefield would be worried about in a wider sense, is what seems to be a a difference in terms of the concerns about the knock-on effect of going for the Imperial and Chelsea and Westminster package as opposed to the Royal Brompton package in terms of the effect on Harefield. And whilst things may have come together much better than they have in the past, that difference between what you're talking about and what Royal Brompton are talking about is worrying in one sense, because understanding what the checks and balances are between those two positions is important for us and important for certainly our residents here and any users of Harefield. I know you've talked about it as we've asked questions about it, but do you see it easily coming together, that what seems to be a bit of a divergence? All right, that's one of those issues that I talked about earlier on, where things come up and we get to hear about them later. Nick and Piers, there's talk in the paper about in our papers about sale of assets under the ownership of the Royal Brompton Trust, obviously, because if there's going to be a work to move, certain of the buildings, as you say, which are many tens, if not hundreds of years old, would be better off not being used in this process and something newer and better elsewhere. To what extent would the sale of those buildings then sort of go into the new proposition that you've put forward?
We would intend that pretty much all of those proceeds would go into, I'll put it into the collaboration. It's not just about a shiny building that we want to create. We want to create a network of care for 15 million people, so South East, South West, North West and surrounding home counties and London. We believe there is an opportunity to do in cardiovascular and respiratory medicine what's being done in the cancer vanguards, trying to join up the different levels of care. And we see that by having three large sets of services, three significant players, we can build consensus around the best ways in which heart valve disease should be treated, not just in the specialist centre, but where it originates in the community and how it should be managed ongoing after a patient's come into the centre for surgery or whatever. So we believe that there's a much more exciting opportunity about a much bigger network, not just the building. And a lot of that will be enabled by not particularly complex or earth-shattering technologies, but technologies that already exist in terms of video conferencing, Skype and other things, but doing that on a robust, shall we say, industrial scale to make a real, really valid network work. So yes, the answer is yes, we would want to reinvest the proceeds, all the proceeds, but it is not just into one kind of, as we said, shiny building. It is about enabling a much wider network.
All right, anybody else got any questions? Councillor Radia.
Thank you, Chairman. Could NHS England perhaps just give us an idea of the types of criteria you will be using to assess the two proposals? It would be helpful to have a bit of detail. Thank you.
All right, thank you. Councillor Dennis.
Thank you, Chair. Apologies if this question has already been answered, but it's sort of a two-phase question, one to NHS England and the second part of it to Royal Brompton and Harefield. I was looking at the processes slide, and I thought I had double vision, but no, there are that many processes in the process, and we are here, and we seem to have a long way to go. I mean, so my first question is to NHS England is, where is the timescales at? When do you perceive all of this stuff happening, coming through? And I suppose my question then to Royal Brompton Harefield Hospital is, will that give you enough time to maybe reconfigure and think about how you can deal with any changes?
In terms of time, in many respects, we want to get on with it straight away. So we've articulated widely that what we would like to do is start integrating our services, bringing them together, even if they're across two sites, but creating one service delivery team in adult congenital heart disease or pediatric congenital heart disease, in pulmonary hypertension or whatever. And things like joint MDTs, shared clinics, honorary contracts, passporting arrangements where literally with an email approval from the medical director, a consultant or nurse from King's College Hospital within a day can be working at Royal Brompton and delivering services. So we want to get on with that straight away because we firmly believe in that the benefits of that scaled up model. I think in terms of the movement of services, to an extent, we are slightly constrained by the physical constraints of the site to which we're moving. So the Evelina Hospital has, for at least 2 or 3 years, been putting forward an expansion plan because it, largely due to its own success, is absolutely packed to the rafters. It has no more space. So it has an ambitious expansion plan into which we, like the cuckoo in the nest, we are now arriving into it, for which they've got to plan for. And there's only a finite amount of space on that sort of Westminster Bridge campus. So to an extent, yes, we would like to work with the timeline that's been set by NHS England. Equally, there are some realities of how we make the space work on what is already quite a busy site.
Just going back to that, I'll come to Councillor Lansdowne very quickly. Just going back to that issue that Nick raised much earlier on in our meeting cycle about when this first came along, about specialists, personnel and specialist surgeons or clinicians and so forth. That's still a concern in relation to any alternative to the RBH proposal.
Absolutely, Chairman. So, for example, the cystic fibrosis service, if chopped up and adult one given to Chelsea and Westminster would have no connection to any expertise of other respiratory medicine. The hip bone's connected to the thigh bone, etc., etc. And I can't put my money on it, but I would severely doubt the attractiveness of being able to work in such a place as opposed to the proposal we're putting forward, which is, mid-21st century technology sort of supported, network-driven, modern care, whereas busting a department which is intermingled so complicatedly with other sort of specialist services, I honestly think it would be very hard to recruit to.
All right, thank you. Councillor Nelson.
Councillor Nelson, Heathrow Villages. I was coming to that decision as well. It's just going wrong in my mind in regards to if it's just stuck on one side, what will happen with the staffing level on the other side? Because if it's going to be chopped into bits and then Harefield will be just adults and then the children goes, what's going to happen with the staffing level? And Royal London, England did mention that proposal on how to recruit, retain staff. Now that will have a devastating impact on the whole changes that's going to happen. And I think our residents will be very concerned to know that the services that is provided by Harefield, how is that going to enable them, that there is something there for them, and not having to travel, because the transportation link as well with that you discussed, you presented, will have an impact. Somewhere along the line, it definitely will have an impact. So I think we need to know a bit more on how that is going to affect the Harefield Hospital and the Royal Brompton.
All right, thank you very much. Well, look, unless anybody's got anything else on this one, thank you very much. You said you'll come back and keep us informed as to progress, and I know that our colleagues from Royal Brompton and Harefield will also do the same. But thank you very much indeed for that. Thank you. Thank you. All right, agenda item 8. proposed move of Moorfield's Eye Hospital City Road services. Hi. Thank you. Welcome to the table, as it were. I know you've been sitting across there listening to all of that. This is a very interesting and exciting proposition, and I suspect you've already been asked to focus on the sort of Hillingdon effect, or the effect on Hillingdon patients as far as this is concerned. But the wider aspect to it is quite fascinating, and the intention to create what sounds like a substantial centre of excellence on a new site is really very exciting. So tell us a bit about it, and then and if you can introduce yourselves for the purposes of the recording, that'd be very helpful.
Good afternoon, everyone. My name is Nick Stratidis. I'm a consultant ophthalmologist at Moorfield, and I'm the medical director there. And what I'd like to do is I'll just start off very briefly giving you a clinical reasons why we're proposing this change, and then I'll hand over to my colleague here, Joanna Moss, who's our Director of Strategy, to go through some of the more business aspects of it. So for those of you who don't know, Moorfield Eye Hospital is the oldest and largest eye hospital in Europe, and it's responsible for training probably about half the eye surgeons in the UK and many more around the world. And it has really three core bits of its business. Firstly, is providing excellence in eye care. The second is in partnership with our university research partner UCL, groundbreaking research in ophthalmology and vision science. And the third thing is in education, in terms of training the eye healthcare professionals of the future. We are a organisation spread across London and the South East, in the sense that we operate out of 31 sites, but what we're talking about at the moment is the services provided by our main site, which is based at City Road near Old Street. Now, this is the hospital where approximately 50% of our clinical activity is undertaken. It is a curious mix, because it is a local hospital treating the secondary care of ophthalmic needs for the local population in that part of inner East London. But at the same time, it is also providing a super-regional, tertiary and quaternary service for ophthalmology, many of which will be the patients from this borough would be coming to Moorfield specifically for that purpose. And also it's a national centre for very specialised services, of which Caroline is the expert in terms of more complex national ophthalmic problems. Now, the Moorfield City Road site has been in existence since the 1890s, and I'm going to use quite a hackneyed cliche which Joe and Caroline have heard many times, but this is a hospital that was built to satisfy the requirements of Victorian surgeon oculists. It was not designed to meet the needs and the expectations of 21st century patients. And so what we have is a building that we are pushing at the boundaries of the technology and the treatments that we have available in ophthalmology, but delivering them in a physical space which has constraints, which mean that we have to provide our services, which have been rated by the CQC as the effectiveness of our services as being outstanding. But we're doing that with workarounds to compensate for the environment that we're in. So whilst we're providing outstanding clinical services, the experience of the patients when they are there is not satisfactory. In my own discipline of glaucoma, it is not uncommon for patients to arrive for what is really a 15-minute consultation, but they are having a 4-hour plus wait with all the various tests and having to move to different parts of the hospital. And the hospital design was not looking at wayfinding for visually impaired or people with other disabilities when it was designed. And so what we are, from a purely patient-centred perspective, a new building would allow us to firstly redesign things in light of the new treatments that are available, in light of what is best practice in terms of how to provide these services to modern patients. But also it's the greater vision of how we are looking at this new building to integrate all the various strands of our expertise. So what we are aiming is to integrate what is now currently separated, which is our research, our basic science research, which is based in a adjacent building but completely separate, and our education facility, and have a co-location of all these services within one building, with the intention to stimulate the interaction between clinicians, researchers and educators in the same environment. And this will be of the greatest benefit to patients, whether they're from Hillingdon locally or nationally, and actually I would stretch to internationally, because this is how we will be able to come up with the best treatments, newest treatments, and also work out what is the best way to provide effective eye care. So this is the ambition of what's called Oriel, the new build that we're proposing. I'll hand over to Joe, who can give you more detail.
Thank you, Nick.
All right, thank you. It's interesting reading the report, but one of the things that sort of leapt out at the beginning was the reference to not just the City Road site, but the 30 other sites being considered as part of the wider review of the ophthalmology model. Are these actual sites, or are they clinics or surgeries or something?
We have different grades of provider sites, but essentially, in most cases, what we have is a full ophthalmology service in about 10 sites, so including surgery, and in other sites it will just be a clinic facility. So the nearest one geographically here will be at Ealing Hospital, where we do full service, all subspecialty disciplines, also and surgery there as well.
So might the idea be that once the new building, I mean, obviously there's a transition, and the great thing with the new building is you can still operate the old ones while the new one is being built. But once the new centre has been put together, then there might be capacity for sort of outreach or satellite clinics similar to that which you've got at the present, in order to have a bit more localism going on.
So with the move to this facility is not intended to replace any of our existing satellite facilities, and of course we are very committed to the communities which we already serve. We are only working in areas where we have been asked to go in by the local CCG or the local hospital. We are in many of the most deprived boroughs of London and the South East, and we are providing the same level of excellence in eye care that we are providing at our base sites. It's an equivalent service at each of these things, and as part of the exciting development of building this new centre, we are actively looking to come up with novel treatment pathways and different ways of providing the care, and the beneficiaries of this will also be our satellite services, where many of these things will get instigated first in the run-up to our move to if we do move to St Pancras.
Dr. Hadjo, have you got any issues, any queries?
Yes, just a couple of points and questions. I mean, I think the other point that I think hasn't been made is actually potentially the benefits for the recipient site as well, because just interestingly, and it's maybe not our primary concern, but interestingly, that part around St Pancras Hospital is the bit that hasn't really benefited from the regeneration around King's Cross, and there's still not really much else there, and there hasn't been since St Pancras Hospital was the workhouse, really, so there's potentially regeneration benefits from a particularly sort of deprived part, I think. I suppose the two questions I have is, one, is it, and it's perhaps not for you, it's perhaps for others, but is the stability of the Western Ophthalmic Hospital going to be affected by being only 5 stops, or roughly 5 stops down the Circle Line? Because the distance is now a little bit further, and clearly that's a consideration. And the other question I have just relates to the scope of services. Is the scope of services going to be exactly the same? Is there, for example, going to be an ophthalmic emergency service on the new site, just as there currently is at City Road?
So I'll respond backwards, and Joe you may have to chip in on some of the more political aspects of this. But firstly, yes, we are not at the moment. There is no intention to scale back or lose any parts of our services. So there will be a 24/7 eye casualty service there. That will be maintained as we have at our current site, and all our scope of our super specialist treatments will remain. In terms of the Western Ophthalmic, it is important to note that is sitting in a different patch from us. It's northwest London rather than north central London, and it serves a different group. I mean, although all our we have virtually, I don't know, 50 odd CCGs commissioned to us. Primarily their commissioners, their core commissioning group is different, and they serve that part of the northwest corridor which we don't serve at the moment. So there's no concern from us in terms of any form of competition regards to that. Joe can comment as to whether there's any specific issues in terms. I mean, there isn't really, as far as I'm aware.
No, I think the only thing I'd add is that we are in dialogue with colleagues from Imperial.
That's what I meant to say.
So we are talking to them. Obviously, we're very aware that they've got their own plans. I understand that the western ophthalmic is part of their redevelopment. So I think ultimately that will move further west. But we are in active conversation with them.
Thank you, Joe. And the last bit is thank you very much for pointing that out about the Bankrest Hospital site. That's actually a very useful perspective. One of the very appealing things for us on that side is, of course, King's Cross is where the knowledge quarter is, and the essentially medical city. We have a well-known partner collaboration with Google DeepMind, who are based in King's Cross. The Crick Institute is there, so there will be our move there will facilitate much better collaboration with these other organisations as well. So thank you for that.
Again, there's as there was in the last point, talk about obviously selling current assets at some point in order to. Well, I don't know if it is in order to feed into the new building, but presumably that is the intention.
Yeah.
Now, as far as consultation is concerned, you've talked about the fact you've had quite a bit already. Are you intending to have roadshows or consultations in each borough, and are we going to get one? Well, in order to be able to sort of answer that one, I suppose we need to get in similar terms when percentages of the, as it were, Hillingdon cohort using the service. Do you have any sort of handle on the sort of volume figures that come from Hillingdon? So it may be worth having a dedicated roadshow in our borough. So that's perhaps something we can talk about and see if we can organise. All right. Anybody else got any other questions on this one? Councillor Riley.
Thank you, John. It's to my understanding that this is the largest NHS project in London at the moment. And you've given us some information about your sources of funding, but I'd be interested to know how much you envisage you'll raise from the sale of the City Road site. And reading some of your documents, it seems as though you are actually expecting some quite large philanthropic donations. And what are your, times are uncertain, what are your contingency plans if you don't hit the 344 million site? It seems as though you're quite reliant upon yourself, because you've got the sale of the City Road site, you've got the funds from the Foundation Trust, and then the Moorfield Eye Charity, and then the small, and it does. from where I am, it seems as though you're quite at risk because it's all sort of quite inward. And with regards to the design of the future hospital, have you taken into account not the current demand but the future demand? We've got an ageing population. Net migration there's still more people coming in than there are leaving, and I imagine that your demand is set to grow and grow. So, what is your current capacity, and what will be the current capacity of this new site? And final point, I think I read somewhere that you were considering. We were talking about the way in which patients will get off at the tube station of Euston and King's Cross and make their way to the site. And I think you mentioned shuttle buses as something you were considering. Just from my perspective, I think shuttle buses are an absolute nightmare. They never work. I think getting around by car anywhere in Zone 1 is virtually impossible. So from my own views, I think perhaps making permanent step-free access from King's Cross. You've already got the RNIB just down the road. And I think a permanent step-free level access from the stations to the hospital would not only benefit your patients but also the wider public. Maybe you could talk to the local authority about that.
Sorry.
To respond to the second point, are you going to talk to the points? Right. So, you were asking about the design and capacity. To contextualise, and I didn't introduce this in our discussion, is that if we were to just replicate what we have at the Old Street site and just add a little bit of extra to account for the growth in activity over 5 years, it would be insufficient to meet the demand. Ophthalmology is pretty much nationally at breaking point. We are somewhat spared at the moment given the activity that we do, but it accounts for 10% of all outpatient appointments now. So it's overtaken orthopaedics as the single biggest outpatient burden to the NHS. And our three biggest disease entities, so macular degeneration, glaucoma, and cataract, are all diseases of aging. So this demand for these things, all of which require surgical or invasive intervention to treat is just increasing. And so one of the challenges about designing this hospital, as well as how we provide our services in the entire network, is how do we ensure that we are seeing patients physically in a conventional face-to-face consultation who really need to be in a conventional face-to-face consultation. So part of how we are going to be delivering our services in the run-up to moving to oral and how we're going to hope to be delivering them is to come up with novel methods of providing the treatment, particularly for patients who are of low risk for visual impairment or who need routine monitoring, for example. So we already have an array of what we call virtual clinics where patients come in who are relatively low risk for, say, retina problems or glaucoma. They have their tests done in quick succession. So this is a consultation that takes 40 minutes, a pathway that takes 40 minutes rather than 3 hours, 4 hours. Those tests are uploaded and then reviewed remotely by the consultant, who is then able to make a management decision. And actually, in some ways, in many ways, it's often a safer pathway for some patients because they're getting all the tests that they have, but whereas in the constraints of a busy clinic, they don't always have those tests. Teleophthalmology will come into play in some of how we do these things, whereby the tests will be done in the community by optometrists in partnership, and they will send over the test electronically for review by the consultants. We already have a trial of that modality in Croydon, which is showing great promise, and we may roll it out elsewhere in the network. And also through our work already that we've demonstrated quite publicly with DeepMind, the ability to use AI for decision-making support will assist at the point where patients are about to be referred into hospital to help referral refinement and also to help decision-making in the community without bringing patients to the hospital. So in answer to your question, there's never going to be a way that we can guarantee how big the hospital is going to be. What we have to do is ensure that who we're seeing in the hospital is being seen appropriately. And that's the biggest challenge, I think, for me and my colleagues in terms of the clinicians providing the care is the time and energy it's going to take to trial these new pathways and demonstrate their safety, efficacy and success.
All right, thank you. Councillor Nelson.
I'm going to focus a bit on the shortfall that you have. You said you're in collaboration with UCLH, and that's a PFI-run hospital.
It's not a collaboration with UCLH. It's UCL University. It's nothing to do with UCLH.
Oh, because that's what I was reading in today. Yeah, so will you be in any collaboration with any PFI to provide the service or the shortfall that will be needed?
Yes.
You were talking very much about, and the paper talks very much about access and getting that last half mile, as you say, and one possible idea being put forward is the use of volunteers at the station who are readily identifiable and to be able to either literally walk people or at least, as it were, physically signpost them. There are lots of entrances and exits, and I don't know what proportion of people would be going through the station, the main station, as it were. But I mean, there's tube there and main line, so actually having people identified that patients can go up to and say, well, where do we go now, sort of thing. Especially if they do have difficult or limited vision, might be one way of dealing with it. But that's and of course you're having discussions with TfL, which is important, and the Mayor's office, because there's a number of different areas of positive health improvement in terms of facilities that transport needs to get hold of, and maybe a joint approach by yourselves and whatever turns out as far as the whichever unit the NHS England go for as far as the congenital heart disease. It's still an issue about movement of people and people getting to places, so it may be a worthwhile thing to have a joint approach. All right. Turco, I was just wondering, anything from Health Watch in terms of that sort of thing, access, and any concerns about that?
Thank you, Chair. Yeah, access would be the issue for us in terms of patients getting to the hospital, as it is sometimes at the moment when they go across the city road. So. And
is Health Watch generally across London engaging in this process for the eye hospital?
I've just logged it down to ask, because we work in partnership with North West London Health Watches. So I've just, as I said, noted it to ask my colleagues in North West London.
Because getting through to Health Watch gets you into a huge cohort of patients and information and knowledge, so it'd be worth getting hold of them.
Yes, we really keen to get engaged. Yep. It's probably worth reflecting the fact that, as Nick alluded to, we've got over 100.
All right, thank you. Well, unless there's anything else from anybody else, it's a really exciting project, and we look forward to hearing about it and how it goes in the future. Thank you very much indeed. Thank you. Thank you. Oh yes.
That side's worth a fortune.
If it comes off, it'd be brilliant. All right, so we're going to move on now to agenda item 9, cancer services in the borough. And we're just getting the right, there we go, getting the right slides up. Is that okay? All right, thank you. So again, if you can introduce yourselves and help us with this item.
Thank you very much for inviting us to come and talk about the cancer services. I'm going to start at the front end of the pathway and talk about cancer screening, and then I'll hand over to my colleague Caroline Blair, who will talk about the other parts of the cancer pathway. So we provide 3 national screening programs in relation to cancer services, which are the cervical cancer program, the breast cancer screening program, and the bowel cancer screening program, of which there are 2 parts, and one is the bowel cancer screening itself, and then the second one is the bowel scope screening, which is the for 55-year-olds. So what I thought I would come and talk to you about today, that I thought would be the most interesting part for you, is about what proportion of Hillingdon residents actually participate within our programs. So I've brought a series of graphs and charts that I hope will become visible to you that show where Hillingdon sits within North West London and how it has performed and changed over the last 8 years. So I think this one starts looking at the breast screening coverage, which is the proportion of people who have participated in the breast screening program within the last 3 years. And as you can see, the heavier blue line, which is now towards the top of the chart here in 2018, has shown an increase over the previous few years. And perhaps it's also worth noting that this is in contrast to what's been happening across the country as a whole, where there is a gentle decline. Just to start that one off on a positive note. Cervical screening coverage, again, Hillingdon is towards the top end of the coverage. But like the rest of the country, we are seeing a gentle decline in the rates of women who are participating in the cervical screening program. There is a lot of concern about this, and there are several national initiatives that have been taking place. So, for example, earlier this year, there was Joe's Cervical Cancer Trust ran a campaign particularly aimed at younger women and particularly through social media sites. And the Public Health England ran a national Be Clear on Cancer campaign, particularly focused on cervical screening. And both of these were quite successful in encouraging women to participate, and we have seen a spike in activity. What we have yet to see is exactly what that's translated to in terms of the coverage of the programme. The other thing that I think is worth noting is that we are at the point of introducing a new test for the cervical screening programme, and we're introducing primary HPV testing. So that's looking for the virus that looks like it underpins cervical cancer, rather than just looking for the cellular changes. So instead of looking for the cellular changes, we now look for the virus first, and if we find it, then we look for the cellular changes. We have just announced that we are going to have a single laboratory for London, which will be at the HSL laboratory on the Euston Road, and all samples from across the whole of London will be sent into that laboratory. That process should have taken every laboratory within London into it by March of next year. And we think it will provide a better service for women. It will identify the women that need to have follow-up, and will equally not pick up those that don't have follow-up, because we know that we get false positives and false negatives within this test, and it should be more reliable for us in the longer term. So that's an exciting thing. But our concern is that women do participate and do come for their cervical screening. I'm moving on to bowel screening. This is a relatively new programme, and we don't have such good data from North West London on this. The uptake and coverage for the bowel cancer screening has been relatively flat over the last 3 years, for which we have the data. However, we also are very excited that we have just implemented a new test for the bowel screening programme, and we now have the fecal immunochemical testing, or FIT test as it is known, which is a simpler test for people to do, in that it only requires one sample to be provided, as opposed to the 3 that are have been. I must put that in the past because we changed on Monday. That has been required up until now, and all the piloting work suggests that we should see a 7% or so increase in the coverage of that, which is very exciting. I have here shown you where you are, just so that we don't become complacent, to show you where you are, which is the thicker blue line, which compares you with similar boroughs across London. And I think we should note here that Hillingdon is not performing so well when we start to look at comparable boroughs across London, which is some of the outer London boroughs, and that clearly there is more work that needs to be done on that. Whilst Hillingdon is performing relatively well in relation to the rest of North West London, I don't want us to become complacent in that it is not meeting the national standards that are set for these programmes, and that there is further work to be done. We have initiatives that we are rolling out or have rolled out. For example, we are sending text messages to women about to remind them of their cervical screening appointments, or to make their cervical screening appointments. I'm delighted that 100% of GPs in this area have signed up for that service. That's early days in that, but we are seeing an increase in uptake. That we are working around the screening capacity to make sure that women can have appointments. I've already mentioned the FIT programme and the primary HPV. We're looking at other initiatives around digital, about whether we can get direct booking through a mobile app, etc., and so on, and the national campaigns. I think that's. We're also looking to introduce text reminders in the breast screening programme, and hopefully for the bowel screening programme in due course. So I think that's probably all that I wanted to say about the screening programmes this evening. Thank you, but I'm happy to take questions.
Okay, I think everybody will be sort of pleased in one sense and not so pleased in another, that we are at a reasonable rate across these various screening procedures. But you talk about further work, obviously, especially in relation to bowel screening, but in relation to the other two as well. What are we talking about? Is this awareness? Is it following up? Is it cajoling and persuading? What?
Well, I think we're from our perspective, we're looking at sending the text reminders. So we're sending that across the whole of London. I think it's also about raising awareness. So there have been the national campaigns, but it may be that there are certain pockets within this borough, that there are particular more local areas that are not identifiable to us at a London level, but may be identifiable to you at a more local level. We have information that is available about the uptake of cancer screening by individual general practices, and we can see variations. So for some practices the uptake and coverage is relatively high, but for others it's relatively low. So it's thinking about how we can target work towards those practices is one area. The other area that we're looking at working at a London level is looking at for people with learning difficulties, because we know that the uptake amongst that group is relatively low. And we are beginning to do some work around people who have severe mental illness, because again we know that amongst that group participation in screening is relatively low.
So in this borough, CNWL are, if not exclusively, then hugely involved in certainly in CAMS and in mental health provision. I know you're sort of pan-London or even nationally, but are you linking with those who specialise in those areas that you've already identified are problem cohorts in order to get them to help with the raising awareness or following up?
Yes, we are. We've done much more work on the learning disabilities, and we're linking up with those services as to how we get the messages through to the people that they're in contact with, and we'll be doing similar things to the mental health services as well.
So who do we go to locally to help to identify those groups that are reticent, less willing, less engaged for these three screenings?
The information will probably be held within the CCG, or they will have access through general practice to that sort of information at a local level, and Dr. Hadjoff may also have that access to some of that information too through the local authority information.
Okay.
Lead for cancer in Hillingdon. One of the things that will make a contribution to the health of people with severe mental illness is that we are now carrying out health checks on all patients on an annual basis. The figures are improving quite rapidly, and the NHSE target is that 60% of these people will have a physical health check during this year. So that's one area which will be addressed. The other that I know about, and perhaps Steve will make greater comment on, is the ethnic differences and uptake by different practices because of the ethnic composition of their patients.
Dr. Hadjoff.
Thank you, Chairman. A couple of things. I mean, I think my first job in public health, which was more than a quarter of a century ago, at North West Thames Regional Health Authority, was around breast screening uptake. And if I recall correctly, Hillingdon was the second worst health authority in West London. West London, Bedfordshire and Hertfordshire, which was our patch then. It's heartening to see that actually on breast screening we've improved considerably. Now, some of the barriers, as Steve has alluded to just now, to screening uptake, have always occurred, and this is true for cervical screening as well as breast screening, have always been present in some minority ethnic groups, and there's a lot of good work that's been done before around how to engage in those communities. And it may well be that there's further work that we can do further to promote engagement. On bowel cancer screening, I think it's very positive that we've moved to FIT testing this week. It's likely that we will get better adherence. People are more likely to actually follow through when they don't have to mess about 3 times. They can just deal with it once. It's also a better test anyway. So I think that's positive. I think the other point that hasn't been covered is, how can I put this? I think there were, and Steve will know more about this than me, I think historically we had significant worries about test kits actually coming to our residents at all. Now, my understanding is that NHS England recommissioned the service about a year ago, the provider about a year ago for bowel cancer screening, and that we've seen an improvement in recent months. But as I said, Steve will know more about that than me. So the final comment I would make is that in our sexual health and service, including chlamydia screening, we've moved to an online model, including self-ordering of testing kits, for eligible people, etc. What's interesting is that we're finding older people are using the online services in proportion to their proportion in the population, if that makes sense. It's not just the young who are using it. And it may well be that we could look at a different model for bowel screening where people could, in effect, self-order, and if they haven't already been targeted for screening, could receive the kits that way. And that could be a way of increasing activity very rapidly.
Sorry. The only concern, of course, is the potential burden on colorectal services, because this will undoubtedly identify more people with bowel cancer who will be in need of treatment. I just wanted, if I could, to move on from there and say that one of the reasons that the CCG has not produced any slides for this evening's meeting is because today Hillingdon Hospital produced a statement about waiting times for diagnosis and treatment of cancer, and we had a meeting together with, and Steve was present, with the STP lead for North West London, who emphasised that Hillingdon at present is the best at diagnosis of treatment of all the CCGs, not only in North West London, but in London and nationally. However, and I'm sure Steve will want to comment on this, there is another side to the coin. Although we are doing well, there is a huge need for improvement.
If I may, Chairman, and I should remind members that this is a particular interest of mine because I chaired the National Suspected Cancer Guidelines a couple of years ago. We are way behind other developed countries in early or timely diagnosis of cancer and timely instigation of treatment. Colorectal cancer is a particular problem. Nationally, it's one of the ones that it's one of the cancers that we diagnose late more than other cancers, but not the only one. So, just because things are improving in Hillingdon are better, our national baseline is poor, and I think there still is room for improvement locally. One of the key, and it's not relevant to screening, but one of the key recommendations that came out of national guidance was direct access to diagnostic services from primary care, in a way to take the load off the hospital or off the hospital consultants. Because if you think about something like stomach cancer, People are referred on an urgent cancer pathway. All of them will be sent for an endoscopy, and 80% of them will not have cancer, and 20% of them, on the basis of current criteria, will, and therefore will need to go through a cancer pathway. Well, if they all had their endoscopy first, then only a fifth of the number of people who need to see the consultant, or who see the consultant, would need to see the consultant, and that could potentially save workloads quite a lot. And that's the sort of national program that's been instituted, but we haven't fully delivered it locally yet.
I think it's also worthwhile saying that we have a well-developed 2-week wait referral system in Hillingdon. But the figures are that only 3% of patients who are referred on a 2-week wait referral actually have cancer. So it's not a good tool, but we don't have anything better at the present time.
Can I come back on that?
Yeah.
If I may, Chairman, just to clarify, that's deliberate. It was nationally agreed that in order to get enough cancers and stop missing so many, we would shift to a system where we refer people where there's about a 3% chance that it's going to be cancer. It used to be that the system was about a 5% chance, and actually we weren't even hitting that. So there's been a deliberate national choice to lower the threshold to get people seen in hospital, either through testing or through seeing a specialist, so that we don't miss as many cancers and we can catch up with our neighbours and with other countries.
Steve, the issue about awareness, not just in mental health but across the board, as it were, as it seems across all three screenings, notwithstanding other ones that there may be. Is that something that can be improved through primary care and through local practices?
And certainly, for example, in the area of colorectal cancer, the GPs next month are going to have an evening of looking at colorectal cancer with input from our secondary care colleagues. And that will include all aspects of the problem, not just the treatment, but also the diagnosis and the criteria that we're using to select appropriate patients. Did you want to comment on that, Joe?
Sorry, I just wanted to come... Hi, this is Joe Noonan, Deputy Managing Director of Hillingdon CCG. I just wanted to respond. So I think in addition to what Stephen's talked about, I think, we've been doing a lot of work with the GPs, and I think you can see that with some of the sort of uptake there. And specifically, we've just ran quite a successful patient engagement event with the Somali community women around, I say cervical screening, not cervical screening, so apologies about that. And I think, so just coming back to your point, I think one of the things that we're trying to do around the neighbourhoods, which are the primary care networks at the moment, is that we're starting to develop more online reporting and dashboarding for them. And I think one of the key things we can be doing here is actually to get some of the, I don't know how frequently the screening data comes in, but I think it's something that we can definitely add to this, because it's something that, it's about getting that information out there and allowing sort of practices in the neighbourhood to see that as well. And we've been developing this for them, for the practices to also be able to see their referrals into acute as well. So it's things that they can start matching together, and it's quite exciting. So it's something we're definitely happy to work together with sort of NHS England on. Also, around people with learning disabilities and SMI, as Stephen has already said, we've got a couple of ways to be able to increase this, because we're trying to work towards a target of getting annual health checks for people with severe enduring mental illness, and also we're trying to reach 100% for people with learning disabilities. So this is something that we can easily add into as part of that. And we've it's very boring, I guess. We've just purchased a software for GPs that will help with clinical decision support. So these are the things that we can build into this as part of that. And then also as commissioners of CNWL as well, who provide service for both, and also we commission sort of the Hillingdon Hospital as well. There's a lot of work we can do around what we call Hillingdon Health and Care Partners to relook at this as well from from both the oncology side of things, but also from a mental health and learning disability side. So we can rework this through locally as well. So I guess Chairman, you're asking who the contact is. We're happy to facilitate that through from a CCG perspective. Yep, and there was a couple of points that I just wanted to respond to. So.
No, thank you very much. And I think that is something that we do want to have happen, and for you to go on with that work. And in fact, I don't know if it's useful or not, but I mean, looking at the figures that Cathy gave us, would we not want to have? I'm not saying a very higher figure, but certainly a higher figure than we've got in terms of. I mean, we're doing well, but we're not doing brilliantly. So would we locally not want to say, I don't know, get to 60% in 18 months or something? I mean, I just pluck it out of the air, but something that's manageable on the back of a greater awareness, greater working between organisations, that sort of thing. But to have in mind, even if it isn't a target that's set, an idea so that you can come back in a year's time and say, well, okay, it was 54% in 2019, but now we're up to 60 or something.
Yeah. I think from a quality improvement perspective, I don't know, this is about making, it's not a target, is it? It's about having achievable goals, and I think it's something we can come back and, taking, Steve and Stephen and your advice on what is an appropriate sort of goal to set, and we can definitely do that, so.
Well, one person's goal is another person's target, so,
Thank you. I think that's very, very welcome, and I think it's very welcome to hear the work the CCG is doing, that we know that general practitioners are very influential with patients and in encouraging them, and positive reinforcement from general practice does have has an influence on whether people participate or not. NHS England and Public Health England nationally are actually wanting to set very ambitious goals around bowel cancer screening. They think that it is a very useful tool, and particularly the new FIT test is extremely effective in identifying people who are at high risk of having bowel cancer. And therefore they feel that they're trying to push us up towards 75% uptake on bowel cancer screening. We're nowhere near that, but there are considerable benefits for people to be screened and to have their cancers either diagnosed early, or in some cases to actually have the precancerous lesions detected before they become cancerous and actually prevent cancers from occurring. So it's a very exciting programme.
Your eyebrows shot up somewhat when Dr. Hudjoff said that he wasn't sure if kits were getting out, or...
I was a bit surprised. Our kits are sent out from our bowel screening hub, which is based at St Mark's Hospital at Northwick Park. So I was a bit surprised to hear that they weren't getting out to Hillingdon.
So if I mean, my understanding was that historically that there was a problem. Certainly when I first came here 5 years ago or so, and for a couple of years after that. That they seemed to be finding their way to Harrow more than they found their way to Hillingdon. But my understanding is that has been remedied. Steve will know more than me.
I just wanted to make the point that by the end of the month, the kits will be available to all GPs in Hillingdon, and the only thing which has held us up has been the publication of appropriate communications to the GPs and their patients. That problem has now been solved.
Can I just come on that? That's is not part of the national screening programme. That is part of the initiative that has been run by the CCGs across London to enable FIT testing to be available for people who go to their general practitioner and are thought to be at a low risk of cancer, as a test to try to differentiate whether they should be going into hospital for further investigation or not. It is such a good test that it is felt that this is a very good use for it as well, and I'm sure that we're going to see a wider use for it too.
Thank you. Councillor Nelson, I think you indicated some little...
in regards to why the information is not getting out or why the test is not getting out, is this because the residents are not responding to what is sent to them? Is it the letters, the GP? And if that is the case, now you're saying that the test is available to GPs. Are you targeting the GPs that is not really providing or the patients is not getting that information? Is that on the agenda? And one more item. In our agenda item 9, there is currently no screening program for prostate cancer, because you haven't spoken about that yet, because the available test is not reliable enough. Can you expand on that?
Can I comment on that?
Yeah, please.
If you watch the BBC News, I can't remember which day this week, there is a proposal that men should have MRI scanning, which is the best way of detecting prostate cancer. And when that is rolled out, that will obviously make, hopefully, a significant difference to the diagnosis of that particular cancer.
So is that the reason? That is now being available?
Yeah, the availability of previous tests has not been reliable, which depend on initially blood tests and then afterwards examination of the appropriate part and possibly biopsy.
I think that the blood tests up to this point aren't really good enough. They're as good as we've got, but they're not really good enough for a screening program. Now, the MRI scanning is potentially very, very good, and so could well, and because it doesn't hurt the person, it doesn't sort of go into their body or anything, it could well form the basis for a screening program. But I believe that there's a little bit more work that needs to be done before.
Yes, just to clarify, I haven't spoken about prostate cancer because it is not part of the national screening programmes. It is available on request if men wish to have it, but it did not meet the criteria that would allow it to be designated as a national screening programme.
All right. Unless anybody's got anything. Right, Councillor Whiteman.
Thank you, Chairman. Is there a significant difference in bowel screening between the uptake for kits versus an endoscopy?
The bowel screening programme is based on a kit test. So the uptake for endoscopy, if it's needed in the screening programme, is only offered after a positive test has been detected. Endoscopy is used if someone goes to their general practitioner with symptoms, then they may then be referred for endoscopy, but that is a completely separate thing to people who are offered screening who have no symptoms at all. I hope that clarifies it somewhat.
All right,
I think the bottom line is that we will have to wait and see, because this new test is supposedly so reliable, but we'll have to get some data to actually find out whether it has a significant effect or not on the detection of this disease.
All right, thank you. The next part of this is about the cancer services on the Mount Vernon site, and as we see on page 33, that a letter was circulated from NHS England and NHS Improvement advising that concerns had been raised regarding long-term sustainability of services provided at the Mount Vernon Cancer Centre and the environment for which they were delivered. So I think we'd like to hear about.
I'm handing the baton over. So I'm Caroline Blair. I'm NHS England Specialised Commissioning and Programme Director for Cancer and Renal Services. So if we're skipping through then the presentation, there is on slide 6 of this presentation. Oops, it's 6. Is it the next one? Hold on. Get my order right. Sorry, it is 8 even, on slide 8. Thank you, Kathy. So this is a review that's being undertaken by Midlands and East Specialised Commissioning, not London Specialised Commissioning, but of the patients who would be treated at Mount Vernon, obviously 40% of those patients are London patients. So therefore there is a board that is reviewing the Mount Vernon site, and it is reviewing radiotherapy services, chemotherapy services, and also the outpatient services at the Mount Vernon site. So the board was established 6 weeks ago, and is actually, tomorrow is its second meeting. So the letter that you referenced, which I don't have a copy of here, has actually come out to interested parties from Midlands and East as the lead commissioner. The reason that it's Midlands and East Specialised Commissioning is that the services at the Mount Vernon site are commissioned by provided by Eastern North Hearts Authority, Eastern North Hearts Trust, and Eastern North Hearts Trust is not a London provider, it's an East Midlands provider. But Specialised Commissioning London are part of the review because of the 40% of the patients being London patients. The meeting tomorrow is in particular looking at options for the site. So 7 options are being developed as to what will happen with radiotherapy and chemotherapy services at this site. Now, probably you're all aware that reviews of Mount Vernon have taken place at different points over the last 20 years, but the main reason that's driving the review at this point is capital investment for the site, and also capital investment for the LINAC accelerators, which deliver the radiotherapy in particular. So a number of things have actually come to a point at which Eastern North Hearts Trust have said to Midlands and East as a commissioner, we need your help. We now need to know what it is that you want to do as a commissioner in terms of the future viability of the services at Mount Vernon. So therefore the letter that you referenced is part of the communications that East Midlands are doing. Oh, hello, you're from East Midlands. Hello. And so I didn't want to steal your thunder then. So would you like to talk to the letter then that's gone round?
So, hello, my name is Jessamy Kinghorn, and I'm the Communications and Engagement Lead for the Midlands and East Specialised Commissioning team, part of the senior management team there. It was touch and go whether I could come tonight, which is, I think, why Caroline didn't realise I was here. I wanted to come really just to explain where we'd got to, because obviously we decided at the end of March, early April, after being approached by Eastern North Hearts, that we needed to undertake a review. Set up quite quickly, I think, a programme board, wrote out to stakeholders. We are doing a number of things as part of that review. We are really at the sort of data gathering stage and looking at what that means for what the options could be. And I'll just run through some of the key things that we're doing as part of that review. So we have commissioned an external independent clinical review, so people from outside the London and the Hertfordshire areas who are experts in their field from other cancer centres to come and have a look and interview the clinicians. They've done a number of telephone interviews over the last couple of weeks. They are visiting the site for a couple of days next week, and they are undertaking some patient interviews and a focus group with a view to reporting back early July. The project team has also been conducting interviews and hearing from staff about what they think some of the key issues are and what some of the key solutions might be. I think there is a broad view that we're not looking for a sticking plaster to stick things. We are looking to try and make sure that this service is sustainable for this population into the future. We are holding 4 patient engagement events in early to mid-July, big workshops in different parts of the patch. So venues haven't been confirmed yet, but we're looking at somewhere around North Hertfordshire, West Hertfordshire, Hillingdon, and somewhere else in North West London. We're also going to follow that up with a few focus groups that will delve further into some of the issues that come out of those workshops, and particularly pick up on any gaps in terms of the people attending those workshops. So if we don't have any younger patients at the workshops, we're going to do a focus group with younger people. And we just want to make sure that we've captured all of the feedback that we can and are able to go into a bit more depth in some areas. We have also been busy trying to gather existing data, both data about the services and the performance and patient access, and also what patient engagement has already taken place. So what patients have already told us or told the organisation about their experience. So we have the National Patient Survey, and there was a report that Hillingdon Health Watch did last year, towards the end of last year, that we've had a look at, along with some patient advisory groups, including a Macmillan advisory group, and some STP-led patient and carer cancer events that have taken place. All of that sort of being fed in to make sure that we're listening to the patient and the public voice alongside the clinical voice, and those are the two big voices really in terms of developing some options. What we've seen is a long list of sort of generic options in terms of the clinical pathway, what that could look like. That needs a lot of further work, each of those options. And the work that's going on with the patients, with the external clinical review and the clinicians at the moment will help us work out how deliverable those options are. And over the next couple of months, we're hoping that we'll be able to narrow that to a short list with the help of patients and the public. There's a parallel piece of work that's gone on. It's been run externally, independently, to do surveys and interviews with patients in clinics. That's going on at the moment. That should also be reporting back over the summer. In terms of a timeline, it's moving quite quickly. As you can imagine, we only set the review up in April, only met as a programme board for the first time in May. It's got membership from London and from the East. It's also got membership from both Hillingdon and Hertfordshire Health Watch. It's got membership from all of the providers. There are about 16 hospitals that feed into the Mount Vernon Cancer Centre, and the CCG's STP leads. It's a big programme board. I think we've got 27 people have confirmed for tomorrow's programme board meeting. I chair a communications and engagement group. We've got 25 organisations represented on that, including both Health Watch again. Should the options that emerge look like they will require a change to the patient pathway or any sort of significant change, we expect to be developing a pre-consultation business case at the earliest in the late summer, early autumn. The earliest a public consultation on any options would take place would be late autumn, so December really at the earliest, realistically. The consultation plan, if we need one, will be developed with public and patient input. We're not preempting what the shortlist will look like at the moment, which is why I'm saying if we need one. I think we're realistic to know that that's a possibility in terms of the patient pathways, but it may not be necessary. It may be that we can have a solution that doesn't require that. I think one of the reasons that I was keen to come today really was to hear how you as a committee would like to continue to be engaged through this process, which as I say is moving quite quickly, and what questions do you have that we can take back and sort of come back to you with more solid answers on. All right, thank you. Dr. Hadger.
Just to add, to update, there was a meeting today with the West London Cancer Alliance, who also have a view on Mount Vernon and the service it provides. Now, I need to be a little bit careful because some of what was said is not it's not up to me to bring it into the public domain, as it were. But I think that they said that approximately 25% of the workload at Mount Vernon is from northwest London, so their catchment. So it's probably between sort of 15 and 20% that are Hillingdon residents.
Sorry, I've got the figure. I took it off a slide that one of the clinicians sent me. 13.09% from Hillingdon.
So I wasn't far off. So that's the situation. I think that there were significant concerns raised about Eastern North Herts as a fit and proper provider, actually, in the light of what's happened with the palliative medicine services that they were providing also on the Mount Vernon site, because certainly my perception was that they were being particularly difficult around palliative medicine in terms of wanting enormous capital redevelopment of the site immediately before they continue to provide services. And to my eye, it was a pretext for them to withdraw from those services. And I'm suspicious that there is something similar potentially happening around the oncology services there as well. Now, there are contingency discussions going on, and there is capacity within West London, certainly to absorb radiotherapy cases, as I understand it, and work is going on about oncology, so chemotherapy cases, and how that could be absorbed, in effect as a contingency plan, because it's unclear how services will remain stable through this process. My understanding is they're already losing staff, and it may be that the services destabilise going forward.
All right, thank you. What's of interest that's of great interest to us, and what's also of interest to us on behalf of our residents and patients is what these concerns were, because very often it's one of those sort of euphemistic words, and also where they came from, what the origins of the concerns are, who started the hair running, as it were, and for what reason. There can be a number of different possibilities to that, but it's important for us to understand. We're pleased, that, in fact, that there is this review going on, because that's a good thing. And it's always seemed to us to be a slightly odd situation to be having a completely different geographical and deliverer of services in a different health area. One of the downsides of that is, of course, that other geographical provider doesn't have any links with the local authority, and may or may not feel at any particular time the need to engage. But nevertheless, we've made some good progress in regard to other issues. But we're very concerned about what these concerns were and are, and where they came from. If anyone can help us with that.
I can provide a little more information on that. So a lot of the concerns relate to the quality of the estate, the facilities. They've had to move outpatients, for example, because the roof was leaking, and there hasn't been the capital investment and the resource that's required to replace estate. I think it's been repaired but not replaced. There is some concern about it. I've been involved in a lot of sort of hospital rebuild type projects over the years, and it's the typical that you can go around and you can take photographs of parts of the estate that are very old and worn and not fit really for the job that they're doing. I think there's been some issues in the last 12 months or so that have brought that more to the fore, and some of the clinicians, both the provider of the service, so East and North Herts, and some of the clinicians independently brought it to our attention. There was an issue around the LINAC. I think we'll find out tomorrow, but I understand that might have been resolved, which is to do with the replacement of the equipment. And I think there are just some concerns around some of the patient pathways in terms of because there is no ITU or HDU facility on the site. If you are undergoing treatment at the hospital and become unwell, you need to be taken to another hospital to be cared for, really, because they haven't got quite the right facilities. And I think the combination of things. The other slight factor is they have seen a lot of growth in terms of numbers of patients being referred to the centre and the number of attendances at the centre, and I think the site's struggling to cope with some of that.
Thank you. Councillor Dennis.
It feels a bit like deja vu for us, because we had an issue with palliative care and East and North Herts, where they seem to come up with similar reasons for not wanting to provide a service anymore, which was valued by the community. Now, I suppose my sort of observation / question is that in many senses, and I go to Hillingdon Hospital quite regularly, buildings and can not be as brilliant as they can be, and there can be issues with them, but ultimately what's most important is that the best possible service is provided in the circumstances that are available. And we heard an interesting presentation from Moorfield's Eye Hospital earlier about how they're moving into new buildings, and that's really amazing and that's fantastic. But I wouldn't have expected them to say if they couldn't have moved into buildings they're going to shut up shop because their old building isn't as good as it should be because it was designed in the 1890s. So I suppose what I'm asking is, while all the stuff that's been said may be of issue, I think what's of most importance is what is the best possible service that can be provided and continue to be provided, and will it be continue to be provided even if there are issues which make it not as well to provide it as they wish, if that makes sense.
So I think the key at the moment is that the clinicians are developing the options in terms of the patient pathway. They feel very passionately about providing the service for these patients. There are, as commissioners, we are committed to providing the cancer services for the populations, as I say, 60% from Hertfordshire, Bedfordshire, the rest from northwest London. I'm not going to preempt what the outcome of the long-listing, shortlisting process might be and what those options will be. I'm not clinical, so I don't want to speculate. We can certainly come back and talk you through those options in the future and make sure that we have a clinician with us that can explain what those patient pathways look like. That's probably the best way to proceed.
Very often, as things progress, I get handed things and things occur to us. We'll come back to this as a specific subject and have perhaps a specific meeting about it, because it's really very important and it feeds into some other things that we've been concerned about as well. So if we may invite you back to help us with this, and probably quite soon, I should imagine, because of the timescale of the review, and to see where we are, and to take a slightly more in-depth look at it than we're able to at the moment. Steve?
Yes, I just wanted to make a small point that one of the expanding areas of treatment for cancer is immunotherapy, and that very often poses a great risk to the general health of the patient, and therefore you must easily have available intensive care facilities, which they do not have at the moment at Mount Vernon.
All right, thank you. Councillor Riley.
Hello, just a quick question. If this site is found to need improvements, this is a Mount Vernon Cancer Centre, and I do acknowledge, if you look at the CQC report, there are issues with the fabric of the building that are highlighted. Who would be responsible for paying for these improvements? Would it be ENHCCG, or would it be the landlord, which is the Hillingdon Hospitals, of that site?
I think that's an interesting question. I think can I bring that one back for a future occasion, because I've got a view, but I'm not convinced. It's not my area of expertise, so I wouldn't want to give you the wrong information.
Councillor Dennis.
Just building on what Councillor Riley said, I think it'd be really useful if there was a clear answer to that question when we came back, because we've had issues with such questions before, and so if in preparation for when your people come back, if they know to prepare a clear answer, even if it involves slides with pointy arrows or something.
Can we? Perhaps it would be an idea, rather than to wait until we fix a date for a more in-depth look at this, for you to come back to us with that answer. And we would want to know, I think, the organisation, the responsibility, the funding stream, and a couple of names as to who it is that's responsible for, and that we can ask about this. Councillor Riley.
And if it is found that the Hillingdon Hospitals, which are the landlord of the site, are responsible for the types of improvements that E&H are seeking. It might be worth having a conversation with THH to find out where they think they're going to find the money, because they're in I think they're running up don't quote me, but it's £26 million deficit. So we don't want to end up at a stage where we enter a deadlock, and perhaps very, very undesirable things have to be done in order to raise the money that THH could perhaps be responsible for providing for these improvements. I think these are conversations which we do need to have sooner rather than later.
Yeah, and I think it's something that we are aware of, and is part of the is this solution deliverable question that we're asking of anything that comes up. NHS England doesn't have a capital budget, so that's another issue in a trust. We can't just give a wad of money and it'll be fixed. So we do need to find a solution that works for everybody. Hillingdon Hospital is around the table. They are part of the programme board and programme team, so they are very much involved. And in answer to your question about whether we could come back to you more quickly, we have a programme board meeting tomorrow. The right people should be in that room. I have a slot on that agenda. I will use that to ask the question.
Thank you very much. All right, well...
sorry, it's just Joe from Hillingdon CCG. So I think just from a CCG response is that we're working through North West London CCGs, and appreciate that. I think the majority of the North West London patients are from Hillingdon. We're also sort of working with Healthwatch at the moment, and I think the key thing here is that I think because some of the issues that are in place around the states and the workforce as well, there might be an immediacy of what we do around options, and I just think whatever we do, we just need to be able to engage with our patients around the options, because we've got to balance between quality, sustainability, and other trade-offs as travel time. But I think initial discussions around potentially sort of relocating sort of the services to Lister Hospital would not be very ideal for sort of Hillingdon residents. But appreciative this is not just about Hillingdon, it's about sort of all of the other services as well. So I just want to put it out there, that's something that we need to look at. And also the other thing is just around that we're, as part of the North West London input into the programme, but we are trying to get a Hillingdon clinical lead on that as well as part of the North West London piece, just to make sure that we've got more of a Hillingdon sort of representation at that board. That's all. Yeah.
All right, thank you. Dr. Hatcham.
Just picking up on Joe's point, I don't want people to misunderstand. If, for example, a choice were made to move that service to Stevenage, to the Lister Hospital, it would not be anticipated that North West London patients in general, or Hillingdon patients in particular, would follow them to Stevenage. They would go to Imperial, or they would go to the Royal Marsden, almost certainly, and receive their care within London.
Okay, thank you very much for that. We'll come back to that and be in contact to deal with that. Thank you very much. All right. Right, agenda item 10, updates on previous reviews. If we can deal with this one fairly swiftly, I think. Yes, please.
Okay, some members will remember that about a year ago, a review was undertaken of community sentencing. The idea was to look at how well the service was being provided. As it turned out, we were unable to actually get the main witness, the community rehabilitation company, to attend any of the meetings. So the terms of reference were basically rewritten, and consideration was given to the effectiveness at all of the community rehabilitation company rather than the service. Recommendations were made and resolutions were agreed at Cabinet to write a number of letters to various different people. You will see in the appendix the resolutions and the action that's been taken. Following on from that, so we only actually had one response, I think, to the letters that were sent out as far as the resolutions were concerned. Following on from that, though, you will have seen recently in the news that the government has decided to bring the service back in-house. So it's no longer going to be delivered by community rehabilitation companies and the National Probation Service, depending on the level. It's all now going to be delivered by the National Probation Service, which I think probably fulfills the desire of the working group and the feeling from the review as it was undertaken a year ago.
There was a great deal of work behind the scenes with the various recipients of these letters and the various associations and organisations that they're part of. We had a response from the chairman of the Justice Select Committee, Bob Neal MP, who was very enthusiastic about the work that the working group had done. And I can't possibly say that as a consequence of the work the working group had done, there was a massive change in government policy, but I do know as a consequence of that letter that it certainly fed into it. It certainly fed into it and influenced it. And I know that other recipients of the letter from the working group about what we found were very well received and were used in order to influence and inform the later government decisions. So I think they should be congratulated, and it shows what can be done when a good and investigative working group comes up with good ideas. That system was something of a shambles, and it will now be repaired. So good work all round. So the final thing we need to look at is agenda. The last part of the agenda items is our work programme. Nikki.
Okay, we have for our next meeting we have our normal health updates. So all of the trusts will be invited to come along and present, but we will also be having an update from the different trusts on the reinstatement of Michael Sobel Hospice and a progress report on what's going on with that. The other item on the agenda for the next meeting, so again I do apologise for it being another heavy meeting, is an update on hospital discharges, which Gary Collier will come along and talk to members about, but there will also be the trusts available to be able to answer any queries that come their way as well. There are a number of meetings on the work programme that I've left empty, which will need to be filled as we go along. So the first one of those will be the March 2020 meeting. And as you'll be aware, issues do crop up quite regularly, so those meetings are quite useful to have in reserve. The other thing I wanted to mention was previously the chairman has requested that members are responsible for a particular trust, and that they are the lead member on that trust for us in terms of researching and questioning, although all members are able to and encouraged to question all of the trusts. Previously it's been Councillor Nelson has been Royal Brompton, Councillor Arnold and Councillor Milani were Hillingdon Hospital, Councillor Lakmana and Radia were Hillingdon CCG, Councillor Dennis was CNWL, and Councillor Barnes was London Ambulance Service.
I think it's worked well in the past to do it to divvy up the research and responsibility for those areas. So if everyone's happy to keep the trusts that they've had before, I know, and if Councillor Harangi would like to take on the London Ambulance Service, which is a pretty big task, that would be very helpful, and we'd be very grateful. They come along when they can. There's a lot of pressure on them, and but when they do come along, they've been very helpful and very useful. So if you could take that up, we'd be very grateful. Thank you. As things have gone along this evening, it seemed to me that at some stage, and perhaps sooner rather than later, we ought to have a meeting on the 3 screening options, or the 3 screening areas as a specific topic. As you saw from the figures, we're doing well, but we're not doing that well in a sense. And it would be wise, I think, to have a meeting focusing on that. even though we've got some good progress in relation to what we discussed earlier on. And we will definitely need to slot in a meeting during the course of the current Cancer Provision Services review at Mount Vernon reasonably soon, so that we can keep... Sorry? It'll have to be an additional meeting, but unfortunately it's something that's being done quickly, which is good. But I think we do need to get a much better handle on that, because it's quite important, and we want to make sure that we've got cancer services in the borough provided by the right people. All right, good. I think we're pretty close to the end of the broadcast of the meeting. So we've finished the public part of the meeting, and thank you to all those who attended and everybody who's watching on YouTube, and we can stop the broadcast. Thank you.